infant before delivery and he will get or perinatal. So it is a during neonatal, during delivery, or immediately after delivery. This is what's meant by perinatal baby. And if you would like to assess the severity and the incidence of this disease, it is very common. This represents about 2 to 3% of every 1,000 live births. It is a large number, okay? And by the time, is it decreased or increased? It's increased. Why? Why was the advance of science and medicine, this number increased? Because we now can support the preterm in a good manner. So a large number of preterm will survive. So a large number in cerebral palsy patient will survive also, okay? So due to large support now of the low birth weight infant, which is a risk factor for cerebral palsy, and now we can support them in a good manner, now the percentage of cerebral palsy has been increased also. Etiology, what are the predisposing factors? What are the causes of this brain insult which happens? Prematurity. Okay, we just enumerate names and discuss about each one of them. Prematurity, the premature we have periventricular leukomalacia, intraventricular hemorrhage, bronchopulmonary dysplasia. A patient, another type of patient which having perinatal hypoxic ischemic injury or having congenital anomalies as regards the brain, having some genetic susceptibility. Multiple births is a risk factor for developing cerebral palsy. Patient will develop stroke, intracranial hemorrhage, intrauterine infection, or acquired postnasal causes, postnatal causes.
Doctor, multiple births is the same of multiple gestation?
Or what?
Multiple births
Is a risk factor.
Is it like the multiple gestation?
Yes. Prematurity. Prematurity is a risk factor for developing cerebral palsy. The percentage had increased in a prematurity. It is now 5 to 15% of surviving in preterm, especially low birth weight, which are less than 1,500 grams, having a large number of developing cerebral palsy. Okay, why? Because they have what is called periventricular leukomalacia. Okay, which is the poor development of the brain in a premature. This is a risk factor. It is some sort of brain injury, so they may have a higher chance for developing cerebral palsy. Also, they are more liable to intraventricular hemorrhage. So this intraventricular hemorrhage and the insult of the brain cells in a premature will have us a good chance to developing later on a cerebral palsy. Bronchopulmonary dysplasia. What is meant by bronchopulmonary dysplasia? Does anyone know?
It's like abnormal growth.
Is it doctor? Did you start, doctor?
Doctor, I think they are asking you to put the mic.
This is a shared lecture.
The male side, can you hear me without a mic? Doesn't need to work.
Okay.
Maybe the bottom.
There's no problem.
Bronchopulmonary dysplasia. Okay, are you familiar with this name? Okay, it is a chronic lung insult. Happened in the preterm due to
Is it doctor?
Yes?
We didn't hear anything from the beginning, so we didn't know that you were starting. Can you just give us a preview of what you said previously?
Okay. Did you attend from the start?
Excuse me?
Did you attend from the start? We started
We
10
were
sharp.
here, but
Yes?
we were here 10 sharp.
We'll talk today about cerebral palsy. Our objective for today will be definition of cerebral palsy, etiology, pathophysiology, types of cerebral palsy, how to diagnose, and preventions and treatment. How to define a patient with cerebral palsy.
So you can use the bullet one.
How to define a patient with disturbed cerebral palsy. Cerebral palsy is a group of motor syndromes. Okay? So the insult here which happens to the brain had affected only the motor part of those patients. Okay, but it has some criteria. It happened as a static type. Once injury had happened, it stopped like that. It is a non-progressive disease, maybe associated with other manifestations like speech, vision, intellectual dysfunction, and sometimes associated with convulsions. Why this happened? This is happening due to injury of the brain cells. At what time? It is either prenatal or perinatal. Prenatal means just before delivery. The mother may experience some problems affecting the oxygenation of the brain of the infant, so he was born with a cerebral injury. Or perinatal. During natal process or immediately after delivery, he developed a brain injury. Cerebral palsy is increasing in percentage. It is now about 2 to 3% in 1,000 patients. But due to successful medical intervention with the low birth weight and successful rate of their survival, the incidence of cerebral palsy has been increasing nowadays. What are the risk factors? Okay, because this is something very important to you in history taking. A patient with prematurity. Patient with prematurity have certain risk factors like periventricular leukomalacia, intraventricular hemorrhage, bronchopulmonary dysplasia. Another risk factor is that the patient may experience a period of hypoxemia, so he will develop perinatal hypoxic ischemic injury. Congenital abnormalities in the patient's brain, genetic susceptibility in some patients, multiple births, stroke which happens to the brain, intracranial hemorrhage, intrauterine infection, acquired postnatal causes.
What we meant by patient here, the fetus or the mother?
What?
Who we mean by the patient? The fetus or the mother?
Patient and fetus.
The fetus?
Yes. Prematurity. Prematurity will increase the risk of developing cerebral palsy, especially in very low birth weight, who is below 1,500 kilogram. This patient may reach 5 to 15% of them may develop cerebral palsy because they may have a risk factors. Okay, very low birth weight have a high instance of developing cerebral palsy, cerebral injury, because they have a risk factors for developing that. One of them is periventricular leukomalacia. Okay, some brain cells are poorly developed in those patients, so they are more liable to brain injury. Okay, another risk factor is those patients may have insufficient clotting factors. So they are very liable to intracranial hemorrhage. Once they have intracranial hemorrhage and have a CNS insult, they may develop later on cerebral palsy. Many patients of premature may develop immature lung. This immature lung will need to be mechanically ventilated for a long time or use oxygen for a long time. The mechanical ventilation for a long time and the use of oxygen with high concentration may injure lung parenchyma, causing a chronic lung disease called bronchopulmonary dysplasia. So bronchopulmonary dysplasia itself and the hypoxemia induced by it, or the use of steroid in treating bronchopulmonary dysplasia may injure the brain, causing more chance for developing cerebral palsy. What about the next etiology? Why cerebral palsy happens? Happens due to injury of your brain by the hypoxemia. So if the fetus experience a period of hypoxemia, which is just a few minutes, even 4 minutes or more, this can induce permanent brain damage. So your patient is liable to developing cerebral palsy. Congenital anomalies. Suppose your patient have been born with a congenital anomalies in his brain. This congenital anomalies of his brain is a risk factor, will increase the chance for developing a more percentage of cerebral palsy. Genetic susceptibility.
Maybe the other one.
Some patients have genetic susceptibility to developing cerebral palsy. The patient which have what is called apolipoprotein E, which is protein involved in the metabolism of fats in the body, which by its disturbance later on you develop Alzheimer's disease. If you have this genetic susceptibility, you are more susceptible to develop cerebral palsy. Another type of patient which have gene responsible for thrombophilia. Thrombophilia means liability to thrombosis. Thrombosis will injure the brain. So if you have this gene responsible for thrombophilia, you have a higher chance for developing cerebral palsy. Some patients have genetic predisposition to develop more cytokines release, more inflammatory markers. These cytokines release and inflammatory markers will injure your brain cells, giving you more chance for cerebral palsy. Multiple bursts. Why multiple bursts are responsible for high percentage of cerebral palsy? The higher the number of fetus, the lower burst weight they will have. They will develop an earlier date, so will have a prematurity risk factors. They are more liable to congenital anomalies by the higher number, and cord entanglement, which will cause hypoxemia for them, and abnormal vascular connections to the which carry oxygen and supply to the brain, so they have more chance for developing cerebral palsy. Okay. Stroke. Of course, anyone will develop stroke natally or immediately after natal. He will have a brain injury. And why can we have a stroke? Some patients have hypercoagulable state, maybe from dehydration, maybe it's a congenital cyanotic heart disease and having a polycythemia. He may have vasculopathy. He may have abnormal development of blood vessels and imply secondary to disorder affecting the placenta of the fetus. So intracranial hemorrhage is not very common, but it is a risk factor for developing cerebral palsy, and when the child or infant having an intracranial hemorrhage, he may develop abnormal movement, seizures and convulsion, apnea, central apnea, lethargy, irritability, vomiting, and bulging anterior fontanelle. Intrauterine infection. Both viral infection and even bacterial infection affecting the mother now is a risk factor for developing a cerebral palsy, a CNS insult. Especially viral, like cytomegalovirus, syphilis, Zika virus, varicella toxoplasma, or are responsible for brain maldevelopment and affection of the infant and neonate by cerebral palsy. Sometimes bacterial infection of the mother can affect the brain cells of the fetus, causing a chance for developing cerebral palsy. Acquired postnatal cause, we said it is a prenatal or perinatal, so immediately after delivery, if the patient develops stroke, have a head trauma, severe hypoxemia, whatever the cause, even it is near drowning, sepsis or meningitis or kernicterus, they may develop a post-neonatal causes for developing of cerebral palsy.
Doctor, what is the near drowning?
Near drowning, it is submersion or immersion. Submersion means that you cover the nose and the mouth inside the water. Immersion totally immerses the patient inside the water. So we will have hypoxemia, drowning. Okay? It is the same. Near drowning, drowning are now the same. Okay? And why is this happening? Why when we injure the cells, this all happens? Because we injure two tracts, the extrapyramidal tract and the pyramidal tract. If you injure the extrapyramidal tract, you will result in this kinetic cerebral palsy or ataxic cerebral palsy. What is meant by the word dyskinetic? This means
Malfunction.
yes, and kinetic means
Movement.
movement. So there is an abnormality in the movement. Let's try if this is going to work or not. He is trying to do a movement. He's trying to do a movement, but it is a dyskinetic. Okay? Another example for this kinetic cerebral palsy. He's trying to use his hand for writing. It is easier for anyone, it is difficult for him. It is difficult to write, difficult to use his hand. Okay?
Excuse me, doctor.
What did you say?
I have a question.
Okay.
About these disorders. They are on levels, right? Some people have it too severe and some people have it mild.
Of
Or
course,
is it
yes.
just one level?
Yes. There is different levels between each of them. We will talk it at the end, okay? But now the cerebellum itself, which is responsible for your gait and coordination, is affected. So you will have what is called ataxic gait. Look to this gait. This is what is called ataxic gait. When the cerebellum itself is affected, as a part of extrapyramidal tract, you will see a patient walking like that. Loss of coordination. This is as regard if we injure the extrapyramidal tract, okay, we will develop two things, either dyskinetic or ataxic. What about if we injured our pyramidal tract? First, we'll have what is called loss of selective voluntary control. When you write, you use only one joint, okay? But if you lose selective voluntary control, you have to use multiple joints to do a simple task. So you will use your hand in writing, not your wrist only, okay? This is what is meant by loss of selective voluntary control. So instead of using just the wrist joint, you will use the elbow and your shoulder also. So it will be a cross movement to do something very simple, okay? Abnormal muscle tone. We have two types to develop of tone in cerebral palsy. You may face a cerebral palsy with hypertonic type, okay, or a hypotonic type. And hypertonic is usually the commonest one, okay? Fixing joint position. As we said, hypertonia is the most common one, okay? So the hypertonia in the muscle tone will cause the joint to be fixed joint. So it loses the mobility because it is now very stiff joint. Preserved primitive reflexes. Okay. If you test a neonate for suckling reflex, you just put your hand above his lips, he will do a suckling reflex. This is what is called primitive reflexes. If you put your hand, if you put your finger in his hand, he will grasp it. Okay, this is a grasp. This is all called primitive reflexes. It is only present in the neonatal period and then disappears. If you found a patient with this persistent reflexes, this is one of the pyramidal manifestation of cerebral palsy. Okay? Clear? Female side, clear till now?
Yes, thank you.
So, on the clinical basis, can we classify cerebral palsy into different types? Yes. On the clinical way now. We have what is called spastic type. If it affects half of your body, it is called hemiplegia. So it can either affect your right side or left side. There is another type of spastic called diplegia. Di means two. So it can affect both upper limb and lower limb, but the main part is the lower limb. Your lower limb is affected. We have also quadriplegic type. All four limbs are affected, and sometimes the upper is affected more than lower, and sometimes lower is affected more than the upper. This kinetic type, I think we have just discussed it now. Okay? So it may be acetoid or dystonic. What is meant by acetoid? Snake-like movement. I'm going to reach my ear, but in this way. Multiple movement to reach the target. Okay? It is not a straight one like that. Okay? So acetoid means the similar to snake movement. In a turning pattern, no, not a straight one. While dystonia, we have see some example of dystonia and ataxic when you affect cerebellum rather than the cerebellar part. Okay? So let's talk about the first and the most common one is the spastic cerebral palsy, diplegic type. Okay. Spasticity affects mainly the lower limb. Affecting mainly lower limb and sparing usually the upper limb. Okay. And it can occur in a preterm infant, usually due to cerebrovascular disease. And this is affecting lower limb more. So his mobility and walking is very largely impaired. Okay? Quadriplegic type. Quadriplegic. So all four limbs are affected, usually in the upper limb more, and having the four limbs affected, he is disabled. So disability here is severe, non-mobile, and usually some of them are affected mentally. Quadriplegic type, you will have a patient, four limbs affected, upper is affected more than lower, and you may have a mental retardation in those patients. And they may have also bulbar affection. So the swallowing is impaired, so feeding is a problem in those patients. So the tendency to have failure to thrive, constipation, hip dislocation, and scoliosis from the huge tone over the joint, so they usually can displace this tone, the joint from its place. Hemiplegic type, hemiplegic means will affect either right side or left side of the body, okay? Usually arm are worsened than the leg, and patient here can walk in some conditions, okay? Dyskinetic can be acetoid, like a snake movement till they do the process, or dystonic, difficulty in doing the process. And mobility is variable. So can we say the cerebral palsy are equal to each other? No. Everyone differs according to what is predominant, hypotonia or hypertonia, and what is the level of hypertonia present on him. We may have what is called chorea-acetosis movement, usually happens due to kernicterus, but nowadays kernicterus had been declined because of rapid diagnosis of high serum bilirubin and rapid removal of this high serum level. So usually we don't see patient with kernicterus now. Ataxic type, when the cerebellum, which is responsible for balance, is affected, you will have what is called ataxic gait, okay, as we see in the last video. Okay. So, I received a question from the female side, are they equal to each other? Are there grades to the cerebral palsy? Yes, there's grades. If you look to the diplegic type here, IQ usually 70% up to normal. Vision, you may have an optic atrophy, and this will lead to squint in some patients. Hearing sometimes impaired. Epilepsy in less than 50%. If you look to the quadriplegic type, you will find that the IQ is the most affected one. It is usually less than 50%. Often there is optic atrophy, and by turns it will be squint. Often impaired, hearing is impaired, and epilepsy in more than 80%. So they are not the same. Some of them may have an optic atrophy squint, some not. Okay, some may have a good IQ. Okay, sometimes may be normal. So it is usually a motor process, sometimes associated with auditory problem, visual, intellectual dysfunction, and others could be completely free, just delayed in motor setting only. Okay, female side?
Doctor, what is sequent?
Squint with optic atrophy.
Yes, doctor.
Optic atrophy. You as a clinician, how to diagnose this cerebral palsy? We talked about a large number of etiology. So if you missed one of them, the history, you will lose the diagnosis. Okay? So a detailed medical history to define out the predisposing factor is something essential diagnosis of cerebral palsy. Neuroimaging. If you suspect this patient having a congenital problems in his brain or have suffered from intracranial hemorrhage, thrombosis, you will do a CT brain or MRI for him. Then you will examine him as a neurological and motor development, because our problem are concerned about the motor development in those patients. Family history. You may have a family history of intellectual disability developmental. This family may have an epilepsy, cerebral palsy, neurodevelopmental delay, joint contraction and stiffness, thrombosis. This family may have a thrombophilia, and the child will quote the same thing from them. Congenital anomalies, usually related to the brain, recurrent miscarriage and stillborn for detecting mother infection, adult onset neurodegenerative conditions because they may have an inborn error metabolism affecting the brain cells rather than it is a cerebral palsy. When you examine the patient, you should focus in assessment of gross motor development. So when you study later on the development of a child, you can compare his chronological age to the motor development. Okay? Suppose he is 3 years old and he didn't walk yet. It's a very delayed milestone. Okay? Motor tone. And we said we have two types of motor tones. The commonest is hypertonia compared to the hypotonia. Posture and evaluation of coordination. Can the patient do some simple things like buttoning, unbuttoning, touch his nose, touch his ears? Okay? It is usually a motor process, but it can be accompanied by hearing loss, visual impairment, intellectual impairment, behavioral abnormalities, communicative and cognitive deficit. So, how you as a physician say this patient who is having cerebral palsy? This is a very good slide, you should consider it. If you receive that patient with abnormal motor development and posture, imagine you have a patient with a contractures in his joint, with hypertonia, delayed physical and mental. First possibility is cerebral palsy until proved otherwise. And one of the specific criteria for cerebral palsy is that we have an injury to the brain and become non-progressive. This is the definition of cerebral palsy. It's a brain damage, non-progressive, usually motor. So motor impairment to the insult of the brain, prenatal or perinatal. And this motor disability may be associated with musculoskeletal problems, epilepsy, disturbance to the sensation, perception, cognition, communication, and behavior in those children. So, at the age of 6 weeks, some infant can follow some object. So if you find this child have inability to follow those objects, consider his cerebral palsy, okay? He may come to you at a late stage with the squint itself. Hearing. Usually when you check a rattle, you know what this rattle means? Okay. This will get the attention of the infant. If you suspect that there is a hearing impairment, do what is called brainstem evoked potential. It is a way of assessing the auditory nerve in a non-cooperative child. Remember that usually the mother can give you a complaint about the patient hearing. So mother complaint should be neglected if she told you that her child is not giving attention to the sounds around him.
Why to be neglected, doctor?
What?
Why to be neglected? Why to be neglected? Why the complaint from the mother have to be neglected?
Not to be neglected.
Not.
We will never neglect any complaint. No. I said we will never neglect the mother complaint about hearing problem in her infant. Okay? Suppose you didn't see the infant in the first year. And the mother wait and wait and wait. Then she come to you at a later stage, after the age of 1 year. Can you tell me, a diplegic type, how can he be presented to you? Diplegic.
Cannot walk.
Yes. Diplegic means his lower limb is affected. So can he walk with hypertonia, with difficult mobility in the joint? No, he will come to you with difficult walking or delayed walking. Hemiplegia. One side is weaker than the other side, so we will not use it. So the patient will come to you using one side only, one hand only. Okay. Acetosis, snake movement. Can he do a fine movement? No, he cannot. This is scissoring. From the hypertonia, he cannot extend his lower limb in front of him, so it will cross. The adductors, okay, are very tense, so they are crossing his legs. So this is called scissoring. Scissor. Do you know scissor? Okay, so this is scissoring, crossing of the legs. This is what is called toe walking. Toe walking. He walks on his toes. Due to hypertonia and shortening of tendon Achilles, he usually walks for a long time on his toes. This is one of the clinical features you should suspect cerebral palsy. If you see one with scissoring during walking or persistent toe walking, this is one of the indications to screen for cerebral palsy. We know all that brain cells does not regenerate. Okay, so it is better to prevent those patients from those injuries. Instruct the mothers not to take any medications not to expose to infection, okay, unless they are medically supervised. Antenatal monitoring to prevent intrapartum asphyxia, because asphyxia is a major cause for cerebral palsy. Preventive birth trauma. Preventive hypoglycemia, because hypoglycemia can injure the brain cells. Preventive complication during management of low birth weight infant. Proper management of neonatal jaundice to avoid kernicterus. How to treat? We cannot treat brain cells, okay? But we will treat the complications which appears. So, in hypertonic patient, we need to do a physiotherapy in order to strengthen the muscles, in order to prevent this hypertonia. Reduce this abnormal tone by giving small dose of benzodiazepine. Surgical procedure to increase the length of the muscles and the tendons in order to facilitate the movement. Speech therapy and hearing aids may be used in patients with auditory dysfunction to help them to talk later on. Any questions? Yes.
Could the cerebral palsy develop after 3 years or 4 years after birth?
No. If it develops after 3 to 4 years, it is a long time between delivery and developing this, so it is not considered cerebral palsy. Search for another cause. We said it is prenatal or perinatal. Perinatal means the short period, just a few months after delivery. Okay? But if he is normal and developed everything normal and starting to deteriorate think for another cause. Think for degenerative brain disease as an example, okay? But don't search for cerebral palsy in those patients. Once he developed brain injury at birth, he will continue to have it. He will not recover for a time, then develop it again.
Yes.
Okay, thank you.
Is it doctor? Can I have 2 questions?
Okay.
So in the beginning of the lecture, there was hypotonia. So you mean hypotonia of the muscles and hypertonia of the joints, right?
No. If you have hypotonia, we have 2 types of cerebral palsy, either a spastic type or hypotonic type. In spastic type, you will have hypertonia and difficult to move joint. In hypotonic, you will have the reverse one. It is hypotonia in the muscles and also hypomovement in the joint. It is very lax, but you cannot combine both of them. Okay?
Thank you. And yes.
Yes.
And the other one is that it means even in the hypertonic situations, it is like, I mean, it is always there.
Yes. Once he is hypotonic, he is almost all the day hypertonic. Yes.
Thank you.
Okay, thank you.
Doctor, can you put us the presentation on the desktop?
What?
Can you give us the presentation on the desktop? Can you give...
But I will modify it for another time, so
Okay.
it is not, it will not be fixed. Okay.
I don't think so.